الرحمن الرحيم. أعزائي الطلبة، السلام عليكم ورحمة الله وبركاته. Today we shall continue our discussion about the physiology of the urinary system and start with tubular reabsorption and secretion. As I mentioned in the previous lectures, urine formation, which is one of the most important functions of the kidney, depend on the three main steps: glomerular filtration, which we discussed it in the last lecture, and the tubular reabsorption and the secretion. We shall discuss them now. Tubular reabsorption means reabsorption of the substance and the water filtered by the glomeruli to the peritubular capillary again. As I mentioned, every day more than 180 liters of filtrate formed. 99% of these are reabsorbed into the circulation. For any substance to be reabsorbed from the tubules into the peritubular capillary, it first should pass from the tubules into the interstitium, then from the interstitium into the peritubular capillaries. The passage will be across the wall of the tubules, either transcellular or paracellular. After they pass from the cell lining of the wall of the tubules into the interstitium, the substance should pass across the wall of the peritubular capillary into the blood. This process of transport again of two types: active and passive. Active transport in turn divided into primary and secondary, and also pinocytosis. Primary active transport utilize directly ATP as a source of energy, and a good example for primary active transport is movement of sodium from the lumen into the interstitium by NAK ATPase pump. Here, sodium move from the luminal of the tubules into the interstitium by primary active transport utilizing NAK ATPase pump. Glucose and amino acids and certain vitamins are transferred together with the sodium. They utilize ATP indirectly, therefore they are called secondary active transport. The other pattern of active transport is pinocytosis, when large particles taken by the cells and utilizing ATP as a source of the energy. Passive transport, which is marked by blue arrows, include movement of substance either across the cell, transcellular, or in between the cells, paracellulars, without using energy. Passive means no ATP expenditure, and the osmosis of water is a good example of this passive movement. Also, urea and the chloride sometimes transported by passive transport. As we mentioned, the primary active transport, a good example is sodium. Secondary active transport, a good example is glucose and amino acid. Passive transport is reabsorption of water by osmosis of other molecules like urea and creatinine. If we look for tubular secretion, this is another process by which a substance which not filtered at the glomeruli move from the peritubular capillary into the what? Into the tubules. certain toxic substance, drugs like penicillin, morphine, most product of metabolism like creatinine, urea, oxalate are secreted from the tubules, from the pretubular capillaries into the tubules to be lost out. In fact, the activity of different parts of the tubules of the nephrons are variables. As I mentioned, a large amount of the water and ions and the molecules filtered by the glomerular capillary into the Bowman capsule at each renal blood circulation through the kidney. This filtrate, as passed through the renal tubules, their volume and the composition are changed. The initial segment of the renal tubules, which is known as a proximal convoluted tubules, absorb about 65% of the filtered water and sodium and chloride and 100% of the glucose and amino acid filtered and more than 85 to 90% of bicarbonate. All of them will be absorbed or reabsorbed at the proximal convoluted tubules. There are a group of drugs which prevent reabsorption at the proximal tubules, and these include the acetazolamide and the mannitol. They are to prevent the reabsorption of the water and certain molecules and ions by the proximal tubules and act as a diuretics, increase urine volume. The second part of the tubules is the loop of Henle, where 20% of the water and 25% of the filtered fluid of the sodium are reabsorbed in the loop of the Henle, and especially in the thick ascending segment of the loop. Drugs which act here and prevent water reabsorption are known as loop diuretics, like furosemide and Burenex and itacrinic acids. These drugs prevent reabsorption of water and electrolyte from the loop, especially from the thick ascending loop, and known as loop diuretics. The next segment of the tubule is the distal convoluted tubules, where 5% of the filtered load of the water and electrolyte are reabsorbed, 5%. And here in this distal segment, the reabsorption of electrolyte, especially sodium, under control of aldosterone hormone. Aldosterone hormone is a hormone secreted by the adrenal gland and act on the distal tubules to increase sodium absorption. Thiazide diuretics, which act and prevent reabsorption of water and electrolyte by distal tubules, are another form of diuretics which used in treatment of certain disease like heart failure or hypertension. The last segment of the renal tubules is the collecting tubules. Here, about 10% or less of the water is reabsorbed, and this area is under control of antidiuretic hormone, a hormone secreted by the posterior pituitary gland, and act on the kidney to increase water reabsorption. If this hormone concentration is high, water reabsorption by this segment is increased. If the concentration of antidiuretic hormone is low, water reabsorption by this segment is decreased. Now, just to review the percentage of the filtrate absorbed by different segment of the renal tubules. In proximal tubules, about 65% of the filtered load of the water and electrolytes, especially sodium and chloride, is reabsorbed. In the loop of Henle, 20 to 25% of the filtered load is reabsorbed. In distal tubules, 5% of the filtered load is reabsorbed. In the proximal, in the collecting tubules, the amount of the water reabsorbed is about 10%, and this is depend on the antidiuretic hormone level in the blood. Sometimes we speak about a tubular transport maximum. Any substance transported from the tubule to the blood and the need energy had a limit, because the carrier which used to transport this substance from tubules to the blood are saturable depending on the amount of the ATP available. When the amount of the substance which is present in the tubule exceed the capacity of the transport maximum for the tubule cells for that substance, the substance will not totally absorb and it is appear in the urine. However, before we reach transport maximum, sometimes the substance start to appear even before the transport maximum, because certain nephrons reach their maximal transport earlier, and this is known the threshold level for reabsorption of the substance. For example, in normal subject, glucose are freely filtered at the glomeruli, and it is totally reabsorbed in the proximal convoluted tubules because the amount filtered is less than the capacity of the tubule to reabsorb glucose. In patient with diabetes mellitus, the amount of this glucose filtered at the glomeruli is too much high, exceed the capacity of the tubule to reabsorb the glucose. Accordingly, not all filtered glucose in diabetic patient is reabsorbed, and a certain or considerable amount of glucose will appear in the urine, and this is one of the features of the diabetes mellitus, presence of the glucose in the urine, because the amount filtered exceed the capacity of the tubule to reabsorb. However, the substances which are passively reabsorbed, they not obey the system of transport maximum. Hormonal control of tubular reabsorption. A number of hormones act on the tubules to modify the reabsorption by the pretubular capillaries. These hormones are angiotensin II, aldosterone, antidiuretic hormone, and the arterial natriuretic peptides. Angiotensin II increase water and electrolyte reabsorption. Aldosterone increase sodium reabsorption. Antidiuretic hormone increase water reabsorption. Arterial natriuretic peptide is a hormone secreted by the heart. It decreases water and sodium reabsorption. It increases water and sodium loss in the urine. Now, how kidney play a role in regulating body fluid volume? It is well known that the kidney had the ability to excrete as much as 20 liters of urine when the body fluid content is increased, as in patients with diabetes insipidus, who characterized by absence of antidiuretic hormone and the passage of up to 20 liters of dilute urine, while the same kidney and under certain volume depletion condition. What we mean by volume depletion condition is a status in which the volume of the fluid is decreased. For example, a patient lost in desert and had no water to drink, or a patient or a subnormal subject fasting in a summer we find that the volume of the fluid is decreased. In such conditions, the antidiuretic hormone will be secreted in large quantity, and this hormone acts on renal tubules to increase water reabsorption and decrease urine volume, resulting in formation of a small amount of concentrated urine. So, in order the kidney had the ability to form a dilute or concentrated urine, this is depend on two main factors: antidiuretic hormone and hyperosmolarity of the renal medullary interstitium. Micturition. As we know, the bladder is a sac, or is a organ, a hollow organ of muscular wall used to store urine before it passes out. Urine is formed in both kidney, passed by both ureters into the urinary bladder, and stored there until micturition starts in order to pass urine out through the urethra. The wall of the bladder consists of a special type of smooth muscle known as the trousal muscles, and it has two sphincters. One of them is internal, involuntary, consists of smooth muscle, and the other is external, consists of voluntarily controlled skeletal muscle. The nerve supply of the urinary bladder is by three groups of neurons: pelvic neurons, which carry sensory signals from the stretch receptor in the wall of the bladder into spinal cord. Also, this pelvic nerve carry parasympathetic motor from the higher center from the spinal cord into the urinary bladder. The next nerve fiber supplying the external urethral sphincter is the pudendal nerve, which is voluntarily control urination. The third fibers is the sympathetic fibers, which supply the blood vessels supplying the wall and the musculature of the urinary bladder. Micturition process is a reflex process. It is regulated in the lumbar sacral region and inhibited or initiated by higher center, especially the pons. When urine starts to accumulate in the bladder in considerable amount, the stretch receptor will send signal to the lumbar region of the spinal cord. Initial contraction starts in the wall of the bladder, potentiated by the parasympathetic motor supply by the pelvic nerve, leading to relaxation of the internal sphincter, and if the subject had chance to pass urine, the external sphincter will be relaxed voluntarily and the subject will pass the urine. Newborn babies or children had not well developed external sphincter, therefore they can pass urine at any time and every time. Thank you for your listening, and good luck for you all.